Welcome to the deep dive. Today, we're taking a plunge into the world of clinical scores. These aren't just abstract numbers, they're practical tools, really, used every day in medicine, helping clinicians quickly size up a patient's situation and, figure out the best course of action. Think of them as sophisticated checklists or maybe algorithms that turn complex clinical info into actionable insights. Our guide for this deep dive is a presentation shared with us from Dr. Tulasi Krishna, which walks through several commonly used scores. Our mission: to unpack these scores based specifically on this material we have. We'll explore what they measure, how they're calculated, according to our source anyway, and most importantly, what they actually mean for patient care. The goal is to help you get a firm handle on how these numbers inform clinical decisions.
And that why is crucial, absolutely. These scores bring a much-needed element of standardization and objectivity, too, to patient assessment. They help quantify risk, moving beyond purely subjective impressions, and provide a common language for discussing a patient's prognosis or likelihood of something specific. The case examples in the source material we have really show the practical application of these tools in action.
Okay, let's jump right in then. The source material lists a few commonly used scores right up front. We see names like CHA2D's TUVAS, Wells score, Curb 65 score, and Center. Now, our source focuses the detailed breakdowns on several of these, giving us the specific components and interpretations. While scores like CMRE 65 and Center are listed as common, the material doesn't detail their calculations, so we'll be focusing our deep dive where the source gives us that granular info. So let's start with one mentioned prominently, the CHA2DS2-VISE score. The material asks, can you define CHA2DS2-VISE score, and tells us it assesses risk factors. What kind of risk are we talking about here, according to the source?
Well, when we look at the factors listed in the table, and then later see its connection to anticoagulation, particularly in case 1 involving atrial fibrillation, it becomes pretty clear this score is designed for assessing stroke risk, specifically in patients with atrial fibrillation, or AFs as it's often called.
Got it. Stroke risk in AF.
Oh.
So what factors from the source contribute to this score? How's it calculated?
Okay, the source breaks it down by awarding points. You get points for age, 2 points if you're over 75, and 1 point if you're between 65 and 74.
Okay, age first.
Right. Being female adds 1 point. Then there's 1 point each for a history of hypertension, renal disease, diabetes, congestive heart failure, and vascular disease. The factor carrying the most weight, the biggest one, is a previous stroke, or TIA. That's a transient ischemic attack. A mini stroke, which gives you 2 points.
2 points for that one.
Yeah. You just add up the points from any of these factors that apply to the patient to get the total score.
And once you have that number, that total score, the big question is, what next? The source gives us some pretty clear guidance, especially about treatment decisions like anticoagulation.
It does. The conclusion slide in the material directly addresses this. It states that according to major guidelines, like the ESC and AHA, you generally cannot simply withhold anticoagulation just based on the clinical scores. The emphasis is that the risk of stroke in these patients often outweighs the risk of bleeding. This score helps quantify that stroke risk you're trying to prevent.
Right, balancing risks. And speaking of bleeding, the source introduces another score specifically for that, the HACE-BLD score. The table gives us the components conveniently in an acronym.
Yes, the HACE-BLD score, it's all about assessing the risk of bleeding, especially, for patients potentially going on blood thinners. It's calculated based on H for hypertension, 1 point.
Okay.
A for abnormal renal or liver function, and that's important. It's 1 point for each, so potentially 2 points there.
Okay. 1 for each.
S for stroke history, 1 point. B for bleeding tendencies or a history of bleeding, 1 point. It's L for labile INRs. That's when the INR blood test for warfarin is unstable, hard to control.
Also wait.
E for elderly, defined here as age over 65, 1 point.
Right.
And D for drugs or alcohol use that increases bleeding risk, 1 point.
So how do you interpret the total HACE-BLD score once you add those up?
The source gives a straightforward interpretation. A score of 0 is considered no risk, 1 to 2 is moderate risk, and anything 3 or higher indicates a high risk of bleeding. The material also specifically points out, and this is a key takeaway, that guidelines clearly state antiplatelet drugs like aspirin have no role in managing the bleeding risk assessed by HACE-BLD in this particular context.
Interesting. Okay, let's look at case 1 from the source to see these in action. We have a 78-year-old female. She has atrial fibrillation and hypertension. No history of stroke, heart failure, diabetes, or vascular disease mentioned. Her BP is up, but kidney and liver function are noted as normal. The source applies the scores here.
Yes, exactly. And the source calculates the CHADS2-VSE score as 4 for this patient.
So how do we get to 4?
Well, Based on the components we just discussed, she's 78, that's over 75, so that's 2 points.
Okay, 2 points for age.
She's female, add 1 point.
Right.
And she has hypertension, another point.
Okay, so 2 plus 1 plus 1. Yep, that's 4.
Exactly. And the Hayes-Ability score for her is calculated as 1 in the source.
1 point. Where does that likely come from?
Well, given the info, it's almost certainly from her hypertension. The other factors, stroke, bleeding history, the abnormal kidney liver function, labile INRs, drugs, alcohol, they aren't mentioned as present in the case description.
Right. So for this patient, we have a high stroke risk CHA2 DS2 Valsgo of 4 alongside a moderate bleeding risk Hayes-Biled of 1.
Precisely. And this situation perfectly illustrates that clinical challenge, doesn't it? Balancing these two quantified risks when deciding about anticoagulation.
Definitely. The source also gives us an interesting update section specifically on the CH2 DS2 VSE score. What does that tell us? Anything noteworthy?
It's quite interesting, actually. It highlights that these scoring systems aren't static, they evolve. It notes that CAK2 DS2 VSE is being found to perform, let's say, suboptimally in some recent trials.
Oh, really?
Yeah, and this is prompting organizations like the AHA to advocate for newer scores, like the Garfield-AF score. It also mentions that European guidelines have even proposed a slight modification, the CHU-DS2-VA score, which notably removes that extra point for female sex in that specific guideline.
So dropping the SCs for sex.
In that version, yes.
Yeah.
It just shows the ongoing research and refinement in how we try to quantify risk. The table in the source listing the factors even includes columns comparing CTBS2-VSE components to those in other scores like Atria and Garfield.
It's fascinating how these tools are constantly being evaluated and updated. Let's shift gears now. Let's talk about scores used for assessing the risk of blood clots in the legs or lungs, deep vein thrombosis, DVT, and pulmonary embolism, PE. Together, that's venous thromboembolism, VTE. The source mentions the Wells and Padua scores for this.
Right. And the material clarifies their different roles, which is important. The Wells score is primarily used to assess the probability of DVT when a patient actually presents with symptoms suggesting a clot, like, leg swelling or pain. The source indicates it has better sensitivity and specificity for diagnosing DVT compared to Padua in that specific situation.
Okay, so Wells is more for diagnosis when symptoms are present. What about Padua?
The Padua score, on the other hand, is specifically designed for assessing the overall VTE risk, so DVT or PE, in patients. People already admitted to the hospital. It's used to identify those who might be at high risk of developing a clot during their hospital stay, perhaps needing preventive measures.
Got it. Inpatient risk assessment. The Padua score components are listed in the source. What goes into that calculation?
The source lists several risk factors that add points. There's active cancer, a history of prior VTE, reduced mobility, known thrombophilia, that's an inherited tendency to clot, recent trauma or surgery, specifically within the last month, being elderly, defined here as over 70 years old, having an acute MI, a heart attack or an ischemic stroke recently, an acute infection or a rheumatological disorder, obesity, and being on ongoing hormonal treatment.
Quite a few factors there. Case 3 in the source seems like a classic scenario for the Wells score, based on what you said. Is a 30-year-old male in the hospital after an accident with multiple fractures. He had hip replacement surgery, was on a ventilator for almost a week because of his injuries, and then on day 7, he develops new swelling in his leg.
Exactly. That presentation screams possible DVT. You've got major surgery, trauma, prolonged immobility. DVT is a significant concern, and the source confirms they apply the Wells score, and it comes out to 5. According to the source's interpretation, that indicates a high probability of DVT.
Right, so the score quantifies that suspicion.
Precisely. It shows how the score helps quantify the likelihood of a clot in a patient with those specific risk factors and the new symptom.
Okay, then case 4 brings in the Padua score. This is a 60-year-old female inpatient. She has multiple existing health issues, diabetes, hypertension, coronary artery disease, severe heart dysfunction from an old heart attack. Now she's acutely ill with altered mental status, fever, signs of infection. The question posed is about preventing blood clots, thromboprophylaxis.
Yeah, this patient fits the profile for the Padua score perfectly. She's an inpatient, she's acutely ill, likely has reduced mobility because of her altered state, and she has multiple chronic conditions.
All risk factors we saw listed.
Exactly. The source calculates her Padua score as 6. Which puts her squarely in the high H risk category for developing VTE during her hospital stay. Interestingly, the Hayes-Biled score is also calculated here, coming out as 2, indicating a moderate bleeding risk.
So again, that balance. High risk for clotting, moderate risk for bleeding.
Yes. And these scores together help guide the decision on whether and how to provide thromboprophylaxis, those measures to prevent clots, weighing the benefit against that bleeding risk.
Makes sense. The source also briefly mentions another score, H2FPEF. What does that one assess?
Ah, yes, the H2FPEF score. Based on its components listed in the source, things like obesity, specifically BMI over 30, hypertension needing multiple meds, atrial fibrillation, age over 60, and some specific measurements from an echocardiogram, an ultrasound of the heart.
Like E ratio and PASP.
Exactly. Those give clues about heart stiffness and pressures. Based on those components, this score is used to assess the likelihood of a specific type of heart failure with preserved ejection fraction, or HFpEF.
And the interpretation.
According to the source, a low score, less than 2, means low likelihood of HFpEF. A score of 2 to 6 suggests further evaluation is probably needed, and a score over 6 indicates a high likelihood.
Okay, so a specialized heart failure score. We did see mentions earlier of other scores like CERB 65 and Center and some other heart failure risk scores listed as well.
Right. The source lists them as, commonly used or just existing scores, which is a good reminder that this is a really big field, lots of tools out there. But our deep dive today, based on the material, is focused on the scores where we got those specific component and interpretation details. Shows a variety, though.
Definitely. Let's look now at scores used in acute cardiac events. The TMI score is presented in the source specifically for predicting outcomes in NSTEMI. That's non-ST elevation myocardial infarction, a type of heart attack. What factors make up the TMI score for NSTEMI?
Okay, for the TMI score in NSTEMI, the source lists several factors that contribute points. There's age over 65, having standard risk factors for coronary artery disease or CAD.
Like diabetes, hypertension, high cholesterol.
Exactly, those usual suspects. Also, prior aspirin use within the last 7 days. Known prior CAD with significant narrowing, like over 50% stenosis. Experiencing more than one episode of angina chest pain at rest within the last 24 hours. Having ST segment deviation on the ECG, the heart tracing, and finally elevated cardiac markers like troponin, which indicate heart muscle damage. Each of these present gets a point.
And the total score predicts risk, I assume?
Yes, absolutely.
Yeah.
The score stratifies patients into risk categories for adverse outcomes, things like death, another heart attack, or needing urgent procedures within 14 days, according to the source. 0 to 2 points is low risk, 3 to 5 is intermediate risk, and 6 or 7 points indicates high risk.
High risk. Okay, case 5 gives us a chance to see the TMI score in action. It's a 68-year-old male, comes in with chest pain. History includes hypertension, high cholesterol, and diabetes. His ECG shows changes ST segment depressions, and his troponin level is elevated. Plus, he's been taking aspirin.
Right, so this patient clearly has several of those TMI risk factors we just listed.
He's tallied them up.
Okay, age is over 65, that's 1 point. He has multiple CAD risk factors, the HTN, hyperlipidemia, diabetes, that counts.
Okay, another point or points, depending how they group it.
The source implies it counts significantly. He's on aspirin, that's a point. He has ECG changes, another point. Elevated cardiac markers, another point. The source explicitly states his TMI score is 6.
6? Wow. And a score of 6, based on what you just said, puts him firmly in the high GH risk category.
Exactly. High risk.
And the material tells us the implication of that high score. It says, for a patient with a TMI score of 6 or 7, there's a significant risk, something like 30-40% risk of adverse events in just 14 days. And crucially, it strongly indicates the need for urgent revascularization procedures to restore blood flow to the heart.
Yes. This case powerfully shows how a score doesn't just classify risk, it can directly drive immediate, potentially aggressive treatment decisions, from number to action.
Really clear connection there. Okay, finally, let's just briefly touch on the score 2 and score 2 OP scores mentioned in the context of managing high blood pressure, hypertension.
Right. These scores, along with one called SCORE2 diabetes, are presented in the source as part of an algorithm, a flowchart really, for assessing long-term cardiovascular disease risk, particularly for patients with elevated blood pressure. For younger individuals under 40 with hypertension, the SCORE2 or SCORE2 OP factors listed include age, sex, smoking status, systolic blood pressure, the top number, total cholesterol, and HDL, the good cholesterol.
And the source shows how these scores then help guide management decisions.
Yes, the flowchart in the material is quite detailed. It demonstrates that these scores are used to calculate a predicted 10-year risk of cardiovascular events, heart attack, stroke, etc. Based on that calculated risk level, which the source categorizes as low, 5%, moderate, 5 to 10%, or high, 10%, the algorithm provides guidance.
Like what?
Well, for low risk, it only suggests focusing on lifestyle measures. For intermediate risk, It might prompt consideration of other risk factors or potentially additional tests like a coronary artery calcium score or checking for plaque in the carotid arteries. And for higher risk, it likely leads towards more intensive management, possibly including medications sooner.
Got it. Case 2 seems to illustrate this. It's a 40-year-old male patient. He has type 2 diabetes and stage 2 hypertension. We also get his BMI and cholesterol details. The source asks what score applies.
Right, so given his age, 40, and his type 2 diabetes, the algorithm shown in the source directs you towards using the SCORE2 diabetes score. The source calculates his 10-year risk using the score as 1.1%.
1.1%. So that falls into the low-risk category, less than 5%.
Exactly. And according to the algorithm's guidance for that low-risk category, the primary focus, even with his diabetes and hypertension, is initially on lifestyle modifications and, reassessing his blood pressure regularly, perhaps annually.
So even with known conditions, if the calculated long-term risk is low, the initial approach might still be conservative.
That's what the source's algorithm suggests here, yes. Lifestyle first. So looking back, we've explored quite a range of key clinical scores from the source material today. We covered tools for assessing stroke risk in AF and balancing it with bleeding risk using CHA2DS2-VSC and HACES-BLE. We looked at evaluating the probability of DVT with Wells or overall VTE risk in hospitalized patients with PEG-UA, determining the likelihood of HFpEF with H2FBEF, stratifying risk in acute heart attacks with the TMI score, and predicting long-term cardiovascular risk in patients with hypertension using the SCORE2 family.
It's really quite remarkable, isn't it, how these different scores take such diverse pieces of patient information, everything from age and medical history to lab results, ECG findings, and kind of boil them down into a number, or a category. A number that directly informs crucial clinical decisions. We saw clear examples. A high TMA score points towards urgent action. Balancing CHA2DS2-VSC and HACES-BLE helps navigate those complex anticoagulation choices. And even a low SCORE2 diabetes risk can still point towards lifestyle as the primary intervention initially.
And it's definitely worth reiterating, as that update section on CHADF2EFC key highlighted, these tools aren't static. They're not set in stone. They are constantly being studied, refined, sometimes compared to newer scores, maybe even replaced eventually, as our understanding of risk improves. It's a dynamic field, always aiming for more accurate prediction.
So what does all of this mean for you, listening in? I think it underscores the increasing role of these quantitative tools in medicine. They help standardize assessment, provide objective measures of risk, and they serve as really valuable aids in navigating the sheer complexity of patient care. They're shortcuts, in a way, but very sophisticated ones, built on a lot of evidence.
And this naturally raises a really important question, I think, for anyone considering these scores. It's something clinicians grapple with every day. As we rely more on these calculated risks, these numbers, how do clinicians effectively combine the result of a score with everything else, with the unique details of the patient sitting right in front of them, with their own clinical expertise built over years, and, crucially, with the patient's own preferences and values? How do all those pieces fit together?
That's a powerful point. Definitely something to think about after diving deep into the world of clinical scores today.